All right, Mac, let's open up.
Well, good morning. And how are you today?
Fantastic. I am ready to start
Good,
a
good.
conversation about um, why on earth is it so complicated to find the right TMJ doctor? Why is it so difficult?
100%. And the second thing is, why do they make TMD so difficult in itself when
Exactly.
all we want to do is put everything in harmony? When the
Correct.
body's in harmony, everything works. When it's not in harmony, it doesn't work. So if the joint's not in the right place, it doesn't work. So, Pam, tell me why the joint's not in the right place.
Well, it's that trifecta we keep talking about, whether it is a posterior interference, a torque mandible, or our most common culprit, a deficient maxilla. As we've been
Correct.
doing this podcast, we've been getting a lot of great feedback from listeners and viewers on our YouTube, right? And we talked a little bit about this last time about if you guys are that are listening or watching, when you read the comments, you can see how people are really struggling. And one of the most common conversations we're having with them offline is like, they're getting so confused on how to find the right doctor for them. Is it the right treatment? What is phase one, phase two? When should I move into phase two? So, this is what I want to open up about today, Mac. Let's try to give our listeners and viewers some clarity on this. So, let's start with the whole topic of why is it that if you come to me and I treat TMJ a certain way, but then you go to another doctor, they treat TMJ a certain way. Why is it so fragmented in our field? Do you want to go into that?
Yeah, so I'd like anytime I had a problem when I was in my office, we had to go back to the source. So let's go back to the source. At least at my age, and you've told me that you were not trained anything about TMD in dental school. So that's really the source. There's supposed to be a movement with the American Academy of Oral Facial Pain to change that. We'll see what happens. Okay, so I get out, and I can only tell you my personal story, and I'm searching for higher learning and that teaches about the more complicated issues of TMD, and not only just TMD, but putting the mouth back together again. And so I sought three different organizations that are still in place, so they're extremely valid. They're give fantastic information, and that's the Pankey Institute, Dawson Academy, and John Quase's courses. And from there, I learned about occlusion and started my journey. Now, you have a different beginning than I did because for the listener, you're going to have to find somebody that has a higher education. You're
Than
going to have to
just
do,
dental school, than just dental school. And
yeah,
that's
the
higher
dental school.
education in and of itself,
Yeah,
but it's got to go so much further than that. Shoot, it's
yes,
still going.
it's still going, and the camps are still fighting. And one of my goals in life is to try to get the camps to talk to each other. So I'm in the process of doing that right now. But tell me your story and how what you learned helps the people who are listening.
Let me break it down like this because it's not about me, it's about them. And like for me, the biggest turning point was one of my patients. His name is Gary. This was like over 20 years ago. Gary, like a lot of patients, came in with worn down teeth. Now, he didn't have the quote TMJ symptoms. He wasn't complaining of migraines and headaches, ear issues, all that stuff. He actually had quote no pain. He just wanted me to fix his smile because his two front teeth were like 4 millimeters. That's less than a centimeter to our listeners, right? And usually a front tooth is at least a centimeter long. So he ground his teeth down so badly. And he's like, will you please fix my teeth? And I was like, Gary, I mean, I don't want to touch you because at that time I was married and I was married. And if I touch his teeth, I'm going to marry him. And I don't want to marry another person too, because as soon as I put a crown or a veneer on, he's going to break whatever I put in there if he broke what's next
Absolutely.
fits, right? So I'm sitting there trying to figure out how on earth there's got to be a way to give this man nice looking teeth that not only look great, but can last, and that's what started my training, my thought process. Why does everybody grind their teeth? Why do some people have pain? Why do some people not have pain? And again, in dental school, they didn't teach us any of that. The I want to and that's what began my journey. And what I was taught on the East Coast is if you're going to rehabilitate somebody's bite, you put them in CR, like centric relation, where you take someone's lower jaw, push it up and back into their skull because it will have a stable position because it's a stopping point. You're jamming the bone up against bone, and that's how you rehabilitate the bite with dentures or any other way. And I remember doing that to patients, and they're like, oh, how uncomfortable it looked and how dysfunctional it looked. So I'm like, this can't be it. And then I searched a whole other process that was about neuromuscular, neuromuscular meaning there's got to be some kind of balance with the nerves and the muscles and how everything works together. And that was more a West Coast concept. I got most of my training at LVI. But anyway, coming out of dental school, and I want our listeners to hear this and understand it because you guys are smart. You guys are looking, you guys are researching, and the more you learn, the more confusing it can get, right? So there's different occlusal philosophies, meaning how to rehabilitate somebody's bite. Like Mac was just saying, there are groups like COIS and Pankey. There is the neuromuscular groups, which the big one was LVI, but now since then that's spun off into Myotronics, and BioResearch have their own programs that they teach these concepts with. There are companies that are completely different that are airway approach, like Vivos. So how can our listeners figure out, holy smokes, which direction do I go? How do I find the right person? And ultimately, it goes back to not just occlusal philosophies, because I want you guys to think of it this way. God forbid you have cancer. You cannot go to 10 different oncologists and expect the one cookie cutter recipe to cure cancer. That's not going to happen. It comes from their education, it comes from their experience with different patients, what's worked and what's not worked. And it also is so much about that person's individual story. What do they come into that office with? What's their symptoms? What have they tried? Have they already been touched? What are they on, etc. So to our listeners and viewers, you have to go back to what Mac taught you. You have to interview your doctors. The doctors have to be willing to listen and take time to understand what are your issues, what are your goals, and then they're essentially become your guide to try to get you out of pain based off of a lot of their own after doctorate education, their history with their patients, their successes and their failures, because it doesn't work. Not everything works all the time. Let's be real, right?
Right. So to break down some of the things that you said for our listeners, because we're dentists, we know what we're talking about. But you mentioned LVI, which is Las Vegas Institute, and I mentioned Pankey, Dawson, and Coyce. Those are still the four main physical schools that a dentist can go to. You also mentioned Myotronics and BioResearch and Vivos. Those are companies that have product that dentists use to find the right bite. And they give seminars because it helps their business. So it's pretty simple how all this works out. Okay, so your LVI brought in a different philosophy, and it's really not a new philosophy. It's neuromuscular that was developed over 50 years ago.
Right,
You
right,
and I are on the board of ICNO, the International College of Craniomandibular Orthopedics. We believe in the neuromuscular. And in my view, in my experience, my vast 50-year experience, the difference between Pankey, Dawson, Coyson, and LVI is the position of the jaw when you are putting either the teeth or the orthotic and putting everything back in the proper relationship. Now, that trifecta that we've been talking about throughout all these podcasts is absolutely necessary for dentures, for orthotics, for a full mouth case, for anything that goes on with the mouth. It is the deficient maxilla, which we've talked about how it occurs. We've talked about what happens with the deficient maxilla and has the jaw pulls back. That was the problem with the patient that had the small little teeth that you fixed. That is an issue that separates a 99% success ratio versus a 60% ratio, which I used to get before I learned neuromuscular dentistry.
Mhm.
So, in their search, you and I believe that they need to find somebody that's been trained in neuromuscular for certain situations that certain patients have. Would you agree with that?
100%. And we have failed to mention this on every podcast. Because we're neuromuscular trained doctors, for our listeners, my advice, if you're trying to find somebody closer to you in your state, go to iccmo.org and there's a tab that says find a dentist. That's a great starting point, but you still need to interview these doctors and make sure that they're qualified because people can get that's one of my favorites because ICCMO is a nonprofit college. We make no money. We have no stake in this game. It is all about putting out good content so that people can get help. So that's my recommendation. But you can also be a doctor, I think, on that list without a ton of training that's newer to this, but at least is still a good place to start. So let's not forget that. I do want to highlight something you said, Mac, that I don't want it to go under the radar. The difference between these occlusal philosophies, listeners, is the jaw position. It's really the jaw position. And that's what it's all about. Do we put it here? Do we put it there? The reason why Mac and I are neuromuscular dentists is because we know that that's worked in our hands. And over, I would say 98% of the cases, not every time. Not everyone can tolerate something called tensing. Not everyone can tolerate oral appliances. And we understand that. There's also a new specialty in dentistry called oral facial pain management specialty, and they also do oral appliances. I don't know exactly how they decide where to put the jaw, but they start with medications and injectables like Botox. It's funny, I had a patient yesterday come in for just routine hygiene visit. She has severe clicking and popping, but she's not in a place where she financially wants to do anything to manage it. Not everybody's ready for that for multiple reasons. That's fine. But she's like, I'm like, how are you doing? She goes, oh, my joints still clicks and pops, but I don't have pain right now. And I'm like, well, what did you do that's different? Because you're complaining of pain all this time and I've been hoping to treat you. She's like, I let my Botox wear off. I was like, what? You're on Botox? She's like, yeah, I was doing Botox for cosmetic reasons. And then I just got too busy with my kids and family life and it wore off. And she's saying that she goes, I feel like the paralysis of the muscles of creating certain strains. And I guess somehow the muscles, support the joint. And even though it still clicks and pops, I don't have severe head pain and neck pain right now. Now we know Botox can help in some ways temporarily, but it can also cause a lot of dysfunction and harm. And people do need
Totally
to
agree.
understand that. So if you're looking for, this new specialty, oral facial pain specialty, they're doing predominantly medications, injectables, and some type of oral appliances. Again, I think the reason why neuromuscular has been my backbone in treating patients is because we do balance the muscles and put the teeth in the right place, put the jaw in the right place, and then everything starts to calm down.
Yeah, until I learned neuromuscular, I was referring patients out because I didn't get the
Huh.
deficient maxilla. And
Right.
so, and then once I found the deficient maxilla, well, then I took almost all the patients. But in the new patient interview, when you're talking to these patients, you really know before you take that patient on whether it's really TMD or not.
Correct.
Because you're talking about the AAOP, which the American Academy of Oral Pain,
Thank
which did a fantastic job in making oral facial pain the 12th specialty in dentistry. But you're right. I have a member of the AAOP. I've been to their meetings, but I still don't know what kind of appliance that they make. And we are occlusal based TMD doctors.
you. Mhm.
They're not, as I understand it, and I want to be fair, that much occlusal based. But you are right. Wearing an appliance for some people is not that comfortable, even though it puts their bite back into harmony.
Well, you
But you,
can't, I can't treat everybody. I have to pick and choose what I think is going to be successful for their treatment, right? And if the reason why you and I both love orthotic treatments in phase one is that we know if we're going to get that patient's chief complaints corrected or not, right? You know as well as I do, they come in with a giant list of symptoms usually because as adults, so many symptom systems has already broken down. So it's not just the teeth that are worn, it's the headaches, it's the eyes, it's the ears. It's a weird combination of these things. So, I always ask these people coming in, if I have a magic wand, give me just two of this list, two things that you want me to eliminate. And when I make that orthotic for that patient and they wear it all the time, if those two symptoms are not at least 80%. I shoot for 80, not 20. Medicine always says 20 is a success. I shoot for 80%. They're not 80% rectified. There's no need for them to go into that second phase of treatment, which could involve orthodontic treatment. It could involve crowns. It can involve both. It could just involve they stay in their orthotic indefinitely. But I love approaching people that way because I know it's going to be predictable. That orthotic becomes the blueprint, like my architectural plan to where I want their jaw and teeth to be later. And they know it's going to work before they
so,
put more money and time into it, right?
I don't, you and I have not discussed this, but when I did accept a patient, it was a one time fee. And so if I did not get the bite right on the first orthotic, what did I do? I made a second one,
Okay. Yeah.
because sometimes you don't take that jaw position, you miss that jaw position. But that one time fee made me and the patient have, like what you said, a marriage. And, you want it to be a win-win marriage. So let's play a little game here, a little mind game.
Ooh, I like
And
game.
let's say, yes, sounds good. Okay. So let's say you're the patient and you have TMD pain and you're searching for the right dentist. Okay, Pam's looking. And so you get on the internet. What makes us dentists who are successful in treating TMD? What's the commonality between us nationwide? In other words, you have education, you have when you call, you have a trained personnel. So what separates us from other dentists, not so much with our clinical skills, but with our people skills and how we present ourselves to the public? What would you be looking for now that you know?
Somebody who is going to listen to me, take the time and hear about what I've gone through and what I'm hoping to improve in my life. Because
So if I call that office, I think, well, this person's got some pretty good education, and I call and I get somebody on the phone that doesn't know what they're talking about. What am I thinking?
the doctor's office isn't, she's not going to know what she's talking about either.
100%.
Hmm.
So then universally, people like us have well-trained staff.
Right.
And I know personally you spend a ton of money on training your staff.
This is true.
You spend a ton of money with me training your staff.
This is true.
So,
My team is
so
very
that is a com
passionate,
that is a com
hardworking. Yes. They work
that's a
just as hard as I
commonality.
do.
But that's a commonality, right?
It
When you
is, yes.
call that office, first of all, the website is well done.
Hmm.
And if they don't have a website, what does that tell you?
They're not investing in anything. I'm
Not
sorry. It's
investing in
true.
anything.
That's
And
true.
for you to know what you know and for me to know what I know, we had to invest a ton of money and emotion and time.
Hmm.
And for somebody listening to this and looking for the right doctor, you're going to have to find somebody that's done the same thing.
Hmm.
It's just common sense. Okay, so now you've made the call and you say, well, that person really did listen to me and
Hmm.
I feel really, really comfortable. And they helped me with the timing of my appointment and all of it made sense. Now, when they walk into the office, what do they find?
It needs to be
a
warm,
commonality.
right? Warm, welcoming. They know exactly who you are when you come in, and the office needs to have that private space, that setting where it is calm and you don't feel rushed in any way. You need to have state-of-the-art equipment to make sure that you can treat these people and diagnose them correctly. You can't do it without the equipment and training, not just my training, but your team. So that commonality needs to exist.
Now, listen, what we're doing right now is we're really opening up because when you're saying that you have to have that equipment and you have to have a well-trained office, you are separating the wheat from the chaff. And dentists don't like to hear that, because if a dentist doesn't have the equipment, they're going to say, wait a minute, you're leaving me out. Yeah, we're leaving you out because that's what you got to have in order to help the people who are in pain.
Right.
It's not rocket science.
That's so true. And you know what's funny, Mac? Earlier, you were just saying, like, what happens if I didn't get the bite right because you don't always catch the joint? That's not an issue anymore, hon, because we have CBCTs, 3D technology in our office. So when I take that bite, not only am I looking at the muscles, making sure it's balanced, I have them take another image to make sure the joint's in the right position, and I'm going to catch that joint working just right.
Okay, so let's get back to the visuals again.
Uh,
Common sense. Okay, so take your left hand and make a C,
mhm,
and take your right hand and make a fist, and have that fist sit into the C. Okay, if
mhm.
your fist is touching your your hand, then the joint's too far back.
Correct.
Well, that might be too far back because the dentist jammed it back, like you said, by manipulating the jaw, and or you have a deficient maxilla, which pushes the jaw back. So when you take your bite, you're making a guesstimate as to how far that joint needs to come out of that C. But with the technology that you have,
Hmm.
you can find the exact position
Correct.
of that condyle sitting in its fossa and its joint, and with the appliance or the bite in place. So you're not guessing.
That is correct. That is absolutely correct. This reminds me of a question that was brought up to us about, a patient is with a doctor and they have some type of oral appliance in their mouth, right? And their phase two treatment is to do a full mouth of crowns, but the joint is still clicking. And they're like, should I move forward even though I'm not having pain, but my joint is still clicking? And that ultimately becomes a judgment call on the clinician. I personally wouldn't, because that says that there's some type of dysfunction still. However, again, if you have the technology that you were just talking about, you understand I'm able to see the shape of the joint. And if you're in your 40s, 50s, 60s, and you've got a mangled up looking joint that when you open and close, you're never going to have some like an absence of noise because that joint is just mangled. It should function. You should have good range of motion. You should unlock. But if you have the occasional crackling or a quiet click, that's a different game. So there's a lot of variables in it. And we really do understand how it can become confusing. You just have to our listeners, now you know about the different occlusal philosophies, you know about the trifecta. You just have to interview the doctor and make sure that that atmosphere looks right, that connection feels right, ideally before you invest any money on orthodontic treatment or crowns, that you're actually comfortable and functioning well. Don't rush this. Most of these cases are chronic conditions, so it didn't happen overnight. A chronic condition took a long time to get there. It takes a long time to heal. So give yourself a few months to make sure things are stabilizing. That's the beauty of using orthotic treatment. And then you can decide to move into phase two treatment.
So I had a patient call me. She'd heard about me on Facebook group. And she said, I like what you say. So I've been to a neuromuscular dentist. I've sat with all the machines on me, et cetera, et cetera. But I did not get any relief. How are you different? And I said, well, did the doctor listen to you or did he listen to the machine?
Mm,
And she said, he listened to the machine and didn't listen to me.
yeah,
I said, I'm going to listen to you.
yeah,
So the bottom line, and you are the one that said it, if listening is the number one key. If I
yes.
take a bite and the patient says, that doesn't feel right, you've got to listen.
You
Now,
do.
they
It's
may
not
not be right.
anecdotal.
I may not be right, but that's why you continue dialogue and continue working until you find a place where everybody feels comfortable. It's all
Correct.
about being comfortable.
Correct. It's subjective and objective data. They both have to work. You can't just look
Absolutely.
to the equipment and you can't just listen to that patient. It's the patient's how they feel is not just anecdotal nonsense. It's real. These
It's real.
people are real, and we have to make sure that they are feeling better. And then we have the sophisticated equipment that validates that objectively. So, do you think we've confused everybody today?
Well, let's do a little recap. We have
Do it.
people with higher learning with Pankey, Dawson, Coyce, LVI, ICMO, neuromuscular, and you just have to do your research and be ready to vote with your feet. If you call the wrong place, hang up. You walk in the wrong office, walk out. I
Correct.
mean, if we're going to tell it like it is, that's the way it is. And so, yeah, that's a lot of onus on the doctor, but that's why we're doctors.
That's right.
It's
Well
our
said, Mac.
responsibility. We work for the patient.
That's exactly right.
Yeah, and unfortunately, there's not a lot of interest in doctors learning TMD because number one, it's too expensive to learn. Number two, it's too confusing. And hopefully, we're taking some of the confusion out of TMD. Get the joint right, get the bite right. Hey, we're good to go. Do it with plastic, do it with porcelain. We're good to go. Do it with moving the teeth. But you've got to know what you're doing.
Well said, my friend, as always. Thanks for wrapping it up so eloquently.
I listen to you.
All right. Until next time, Mac. Bye,
All
hon.
right. See you later. Talk to you later.